Good morning, class. Dr. Hastings here. Hope everybody's good. I think I have the screencast-o-matic set properly, but in case we're falling off the screen a little bit, I wish you a good start to your week. And this week we're going to talk about teaching in the clinical environment, to which I suspect all of us have some experience here, and we have some appreciation for the way this looks based on our own personal experience and having had an instructor with us. We tend to think, what kind of instructor would I like to have to be able to get the best out of my clinical environment? But of course, there's so many different variables that instructors need to be conscious of, and that includes the clinical unit, the teaching environments that we use, of course. But we'll talk about that in a minute. So I just want to give, again, a brief overview, as I do every week, regarding this topic. And to start, let's just talk about, what we're doing. Clinical instruction at the site. A lot of us have obviously been talking about alternative ways of instruction in general. Why not clinical instruction, i.e. simulation continues to evolve in many different ways and approximates the real thing. So, interesting to think about. Is it close enough? We talk about the value of having real hands-on experience, but does simulation get close enough for us? All right, so clinical agency access for us with clinical teaching, where are we at? Typically with acute care settings, as we remember from our own experience at undergraduate environments, and of course in the graduate level you may be more in the outpatient realm, that depends. In tertiary based or rehab settings, certainly nursing homes run the gamut, but let's just say anywhere where there's a residential presence, and for me, with my genre, I tend to be more thinking about drug and alcohol rehab. And then community and public health clinics and centers, becoming more and more important for us to be able to navigate those, and therefore for students to get exposure. So we tend to think about students getting exposure when they're in public health nursing. What about before that? Should we have a regular appetite of exposure throughout a curriculum? That's a key consideration. And for healthcare systems, thinking about, again, novice nurses who are in orientation with the idea they're going to be in the acute care side, the hospital, what about serving the system, and what about orientation at outpatient centers? So that's something to consider then too as we roll forward. So in all that, we think about the domains of learning, even in the clinical environment, because we tend to easily fall into, this is hands-on, this is just psychomotor, but of course it's not. The knowledge, skills, and attitudes, the ability to effectively deliver care to a patient. So it's really important. So I said, you got to teach them all. Is that a throwback to Pokemon, I think? Anyway, you know how much money I spent on Pokemon for my kids? Anyway, but in all, consider your level of student. In academia, of course, that whole notion about where are they? How ready are they for any given clinical environment? So we need to appreciate and understand the difference between a junior level student, I would argue between a first versus second semester junior level student, after they've had some clinical exposure, versus seniors, of course, and then relative to novice nurses, new nurses at orientation. And two, how do they progress? How ready are they for the real thing, so to speak? And that influences such things as how long should their orientation be and how intense. All right, realizing that in the real world, it's high complexity. So we seek it out because we want good experiences for our students, but we don't want to put them in an unsafe situation either. So that's important. Plus the other things that contextually are drivers within the clinical instruction landscape, EHR, electronic health records, and decision support system, medication administration systems, Pyxis, Omnicell, what have you. So all those things are important and relevant to how we consider clinical domains, good sites for our students. So virtual, again, we mentioned simulation before. What about virtual clinical practica, electronic ICU type of situations, and telehealth I mentioned here are growing modalities. So if anybody has something to share on this when we're in the DQ, that would be great too. These are arguably less hands-on directly, technically. But again, with the proper tweaking, we can support even better complexity and not have to worry about finding the right situation, the right patient, the right set of skills needed to learn, because sometimes that doesn't happen. We always have students coming out of academic programs say, hey, I never got a chance to do a central line or a Foley even. So things like that. I mean, I think we think about how else can we support what are important skills and processes our students need to learn, and what medium can we do that. And for me, in psych, obviously, I think about the effective part then too. Can we still test that in a virtual scenario, or through telehealth modalities? So that's important to consider. All right, what about community-based? Because we know healthcare is shifting towards the community. So what does that look like when it comes to settings like ambulatory care and long-term and home health and clinics and all that? We want our students to be exposed to these. Now, oftentimes those experiences, of course, tend to be more, let's just say, a day or two external or internal rotations within a clinical practice, just exposure. So they tend to be more observational. But should they be more? That's a question, I think. All right, so concerns. Remember, we have to make sure all the agencies are approved, so that's a state board process ultimately in terms of getting contracts with agencies. So clinical coordinators lament about these things. We're very fortunate to have one at Cedar Crest right now, or a couple that are supporting that. So, but then we worry about census, we worry about acuity, those kind of things, which sometimes fluctuate in agency. So sometimes the optimal agency doesn't look optimal when we get there, or in a given part of the year. Where do you always hear it? With peds. There's not enough patients to support our peds rotation. That tends to be classic. Or for me, pediatric mental health. Now, we're fortunate at Cedar Crest, we go to Kids Piece now, but if there was just a dedicated adolescent or child treatment unit, that sometimes goes really low, so that's difficult. All right, so anyway, considerations there. Effective clinical teaching behaviors. So create an environment conducive to learning, so I say a culture. So knowledge of the practice area, knowing the specialty, clinical competence, and respect to who we are. So we have to be good practitioners and know our genre. And that's hard sometimes when we're teaching over different genre. That's not always an easy thing to negotiate. And then, knowing how to teach, being fully prepared and motivated to do so for our learners, but we're knowledgeable about them as well and what their needs are. So that's really important, relative to engaging students. Because sometimes it sounds like just a nice thing. Sometimes when we hire adjunct faculty, we're thinking, oh yeah, I'd love to do that kind of thing. But is it just a side job to earn extra bucks or a drive-through experience? Then it gets edgy. So we want to make sure everybody's on board on the same page. All right. So focusing on maximal student learning capability. Diagnose their needs. Consider, in effect, into personal capabilities. So your students in a cohort, let's just say 8, 9, 10 students, are going to look very different in terms of their skill, their KSAs. So we have to recognize that and be able to work with them individually. And some students you have to work with more than others. All right. But, we foster independence and accountability so our students learn. So we hold them to be responsible for owning their practice. Okay, but we also recognize that sometimes there's barriers in the clinical environment, and some tense cultures, some treatment environments aren't too fun out there. So, and always encouraging questions, guaranteeing that they are heard when we can't guarantee how the unit's going to be, and we need to foster debriefing. That's what's cut off with the picture here feed, and be prepared sometimes for an adverse unit or an adverse co-assigned nurse, that type of thing. So in all, accept differences amongst students, and we certainly have to address their individual needs and differences and communication styles, possess effective communication, question skills, engage them. Engagement is really important, and serve as a good role model. Be vested in the process and to keep the bar high. So in all that, effective clinical teaching behaviors in general include, from our standpoint, to your students and to the staff at the agency, be friendly and approachable, be knowledgeable about the subject matter, know your stuff, be fair and balanced, and provide frequent feedback. So that's really key, I think, here then too. And something that clinical instructors oftentimes get backed up on at times, and that's hard sometimes to dig out. I'm right in the middle of that with my last clinical day with students too. So, all right, so that's it relative to the part 1 experience. I want to go to part 2 for a moment. And this refers more to, and let me bring this into from the beginning. Here we are. This relates more to the prep of faculty. How do you get ready to be a good clinical instructor? Billings and Halstead referred to the idea that faculty need to understand evidence-based teaching strategies and to be able to appreciate at one level the ability to effectively engage and understand theory application. So to get ready for those kind of things, think about immersion. Think about things such as boot camp. Think about, I just want to change the, excuse me one second, I just want to change my video here to bring it in so I can see my timeline. Sorry about that, guys. There we go. Okay, very good. So to that end, think in terms of the way in which you need to be prepared. And besides just getting an orientation of being a clinical instructor, think about a boot camp, an immersion type of situation. I like that article by Reed that was mentioned in B&H that I brought up, how a boot camp was developed, or a nursing educator academy. So hence, like what National League for Nursing has. So check out that link. That's really good. And then being able to, in prepping, having a mentor still on board for you, okay, that's helping guiding you through the process. So again, beyond just some type of orientation, dedicated online workshops also are very helpful in socializing clinical instructors. So I put some supplemental reading that touches upon some of these things. And then we have to think about setting the stage for a good student clinical experience. So some of that is just being prepared while having an assignment sheet with lists of students. This is socializing the students at one level in parallel to the unit itself, but really this is more about the staff being ready for us to come on board, for them to receive our students. Talk to the charge nurse, talk to the staff, make sure you're developing relationships. I think that's really important, that we're all on the same page. And they look forward to having us, that we complement the unit, as opposed to sometimes the unit, it feels like we're in the way, so that type of thing. I hear that from students on occasion. And then do some rounding then too. Make sure patients are okay to work with students. We think that's implied at teaching hospitals, relative to even when they fill out informed consent when they're admitted. But that's not always the case. That happens obviously with medical residents a lot in teaching hospitals. I think we need to think about that relative to our nurse clinical rotations. That's not always a given. And then there are gender issues sometimes relative to having students. So, all right, think about level like we talked about in the other slide deck. What would make sense relative to the assignment load. So maybe one patient for juniors, and we move that up with seniors in the academic setting. Same thing with orientation. Novice nurses, we start low and then end high, obviously the numbers being a bit higher. But in all this, keep in line with the idea about protocol, and keep in mind the learner needs relative to the environment. Remember, we're patient-centered first here, because we're erring on the side of caution, safety, and being good guests to providing good care in a clinical agency versus the learner-centered first. Sometimes, learners or students have to sort of bite their lip and take a back seat to the patients, in effect. Traditionally, we think about conferencing in pre-conference or mid at lunch or post-conference. Just keep conferencing on board as a really important part of your teaching pedagogy, and keep it focused on nursing process. We want to hear about the experiences, but we need to think about nursing process as a staple here. And then, can we do this online? Because clinical time is so sacred and seems short. Is there a way to do that? So that's an important modality to consider, I think, when we talk about other options to clinical instruction. Also, with other assignments, think about things that get students on board at the beginning of a rotation, scavenger hunts, and the assessment tool that we use, get them socialized to it, the EHR and care plans, let alone concept mapping. I think the page is falling off here, so I apologize, but we're near the end. So concept maps are key, I think, in terms of instruction. It helps. And then journaling. They need that reflection. They need to review how they felt about their clinical day, to gauge their level of confidence, and to do some process and quality improvement relative to their experience. So that's really important, reflective context. Models for instruction. You can see this slide. The DEU is my favorite. Love to be on board with that. And nurse residency programs would be awesome. All right, great to have your attention. I will see you online.